Hi and welcome everybody to my presentation. Today I'll be presenting a case under the title of Novel Way to Treat Autoimmune Epilepsy. So currently our patient is a 19-year-old male who is known to have a gut-positive autoimmune encephalitis diagnosed at the age of 14. His symptoms are consisting of refractory focal and generalized seizures, movement disorders in forms of myoclonic jerks and tremors, ataxia. He also has learning difficulties and behavioral issues, and also recently dysphagia. Now, in order to know how he presented, let's go 10 years back when he was at the age of 9, presented to the emergency department with the first episode of generalized tonic-clonic seizure that is believed to have a focal onset, followed by multiple episodes of seizure. During that time, he was previously healthy. He had a normal vaginal delivery, no pre or postnatal complications. He met all of his developmental milestones that are appropriate for age. His vaccination was up to date. Family history was positive for consanguinity as both of his parents are first-degree cousins. He has other 3 healthy siblings. The family history was significant for mother's uncle who had epilepsy and died at the age of 19. There is no confirmed diagnosis. However, it was believed to be a sort of progressive myoclonic epilepsy. His examination is completely normal during that time. Investigations in form of brain MRI was normal. His EEG showed a focal focus on the right temporal region, and also some subclinical seizures were depicted. He had a normal electrolytes and normal inflammatory markers during that time. The seizures were initially well controlled with the oxcarbazepine. However, a few months after the onset of his seizures, his mother reported other symptoms of progressive imbalance and falls. So it was believed that these are initially myoclonic jerks, and that's why they started him on clobazam to improve the myoclonics and hence to improve the falls. However, the patient was continuously having more severe imbalance, and also he was having more frequent falls and ataxia, and he was nearly dependent on activities of daily living. He was unable to walk unsupported. And as the child was growing up, more symptoms were added to the picture. He started to get myoclonic jerks that were very clear in upper and lower limbs, orofacial dyskinesia. He started to have also dysarthria and behavioral issues in forms of agitation, hyperactivity. At one point, he also started to have auditory hallucinations, and he was doing well academically before. However, he started to have some learning difficulties, especially in some of the complex subjects like mathematics, and also started to get more breakthrough seizures that were difficult to control, so Topamax was added to control them. During that time, of course, his examination was abnormal. He had ataxic and steady gait, abnormal finger nose test bilaterally. He had intentional tremors, very clear dysarthria, orofacial dyskinesia, and also myoclonics in upper and lower limbs. So at this point, it was clear that the patient is not having simply an idiopathic epilepsy. There is something else driving all of these symptoms. So the list of the differentials were divided into autoimmune encephalitis, progressive myoclonic epilepsy, mitochondrial diseases, central nervous system neurotransmitter diseases. So they were mainly metabolic, autoimmune, or genetic. And these differentials were thought about when the patient was at the age of 13. So brain MRI was again repeated and it was normal. And in this case, also MRI spine was added. Again, it was normal. LP was performed and showed only elevated proteins. Now, other complicated and more specific tests in forms of whole exome sequencing, mitochondrial genome, and the CSF autoimmune encephalitis panel, all of them were sent. However, the results would take a long time to come out. So the pediatric neurologist, they decided to start him on treatment that will cover the autoimmune encephalitis part. And they started him on 5-day course of IVIG and metalopred. And there was a marked improvement in his symptoms, like the ataxia, the dysarthria, and the tremors, and also the orofacial dyskinesia as per the mother. And at this point, his seizures were controlled with the oxcarbazepine and Topamax. Unfortunately, during that time, he lost follow-up because he traveled abroad to seek another opinion and also for the continuity of care. And this was for more than a year. So the patient returned from the States and the final diagnosis of gut-positive autoimmune encephalitis was given. Even though the titer was low, but they think that all of his symptoms are related to gut autoimmune encephalitis. He was on symptomatic management and also disease-modifying therapy. So for the symptomatic, Capra was added to the oxcarbazepine. And also they added diazepam and risperidone for the behavioral part. Now for the disease-modifying therapy, they continued on the monthly infusion of IVIG. He received his first dose of rituximab over there, and also mycophenolate was added. When he came to us, we continued with the monthly IVIG and the Q6 months rituximab. However, the patient was deteriorating clinically. So at this point, he has refractory epilepsy that are mainly focal with secondary generalization. He has a collection of abnormal movements in terms of myoclonus and tremors, causing severe motor disability and dependency. He has ataxia, poor attention, behavioral and cognitive impairment, and also causing learning disabilities and difficulties at school. So now the patient is 15 years old, and pediatric neurologists, they started to think that they need to add something else for him since he's not responding to the other therapies. So they decided to start him on plasma exchange and see the response. They gave him 6 sessions of plasma exchange, and he was improving dramatically. He was able to talk, he was more awake, and also he was walking independently and going to the washroom and walking in the house without the need of any support from his mother or the caregiver. So because his response to the plasma exchange was dramatic, it was decided to give him a maintenance therapy of plasma exchange weekly. The patient continued to receive Flex as a maintenance therapy weekly for a few months. And after that, again, he traveled abroad for the continuity of care and also to seek another opinion. And he lost follow-up for more than a year. So when he came back, unfortunately, at this point, he was bedbound. All of his symptoms were worse. And pediatric neurology, they continued to give him only the IVIG and rituximab without the Plex. At the age of 17, patient was transferred back to neurology. Patient was transferred to adult neurology at this point. We continued the monthly IVIG and rituximab every 6 months. And we repeated the autoimmune encephalitis panel because all of his investigations that were done by pediatric neurology, the mitochondrial genome and the whole exome sequencing were negative for any pathogenic gene that might be responsible for his symptoms. And also the autoimmune encephalitis panel was negative, but the GAD specifically was not tested during that time. So here, when he came to us, we tested the autoimmune encephalitis, the entire panel, and also we made sure that GAD was involved. So GAD again came weekly positive, just like the result from the States. And at this point, since the patient initially responded well to the IVIG and the plasma exchange, we decided to start him on another disease-modifying therapy that somehow has the same mechanism of action as the Plex and IVIG by facilitating the clearance of the pathogenic autoantibodies from the body. And this is the efgartigimod alpha, which is an FDA-approved medication for myasthenia gravis. We followed the same dosing schedule that was used for myasthenia gravis in the trial, which is like a weekly dose for 4 weeks as a whole cycle. And then the cycle would be repeated based on the clinical demand. But till now, the patient only received 1 cycle that consists of a weekly dose for 4 weeks. His response was significantly amazing. His tremors, myoclonus, and seizures, all of them improved, but of course not 100% disappeared. He was more awake, more cooperative, and the mother was very happy with the outcome. Now, autoimmune encephalitis is when there are autoantibodies targeting self-antigens expressed on the central nervous system. The classical example that comes to mind whenever we talk about the autoimmune encephalitis is the NMDA encephalitis, which has a very acute course. It's usually monophasic, however, in 30 to 40% of the patient, they may have a relapse. The anti-GAD encephalitis, which our patient has, it has more of a subacute onset and usually tend to have a chronic progressive course. There are many different symptoms in forms of refractory seizures, movement disorders, stiffness of the body, muscle spasm, cognitive decline, slurred speech and walking instability. And as you see, our patient had most of these symptoms. And it is believed that the epilepsy part in this autoimmune encephalitis, it is under the category of autoimmune epilepsy. That's why it's not really responding well to the regular anti-epileptic medication, and it needs immunotherapy early on in order to control the seizures. The first-line therapy for the autoimmune encephalitis is the corticosteroid, immunoglobulin plasma exchange. Second line consists of the alkylating agent and also some of the monoclonal antibodies targeting B cells, specifically rituximab. Now, in literature, there are some of the new drugs suggested as first line that might be used in the future, which are the other B cell targeting therapy, like the ocrelizumab and the inebilizumab, the IL-6 inhibitors, like the tocilizumab, the cetralizumab, the neonatal Fc receptor, which is the one that we use, the efgartigimod, and the rozanolixizumab, and the complement cascade inhibitor, which is the eculizumab. Now, when it comes to the medication that we use, the efgartigimod alpha or the Vyvgart, it is considered under the category of the neonatal Fc receptor antagonist. Now, in order to understand the mechanism of action of this drug, you need to understand what is the neonatal Fc receptor in the first place. So the neonatal Fc receptor is an intracellular receptor that belongs to MHS class 1 proteins. It has an alpha chain that is associated with beta-2 microglobulin. It functions in the recycling and the transcytosis of the IgG specifically, without altering the IgM and the IgA. And how is that? The Fc receptor, they would bind to the immunoglobulin. Inside the endosome, it will prevent the lysosomal degradation of these immunoglobulin and then releasing them back to the bloodstream, hence prolonging their half-life. This is for the recycling process. The other process, which is the transcytosis, it's simply transferring them from one side to the other side. And the classical example of this is the transplacental transfer of the maternal immunoglobulin to the fetus, which gives the fetus the passive immunity, or even sometimes can give a fetus some of the immune-mediated diseases that the mother already has by transferring the pathogenic antibodies. So now we know that the Fc receptor is involved in autoimmunity. Blocking this receptor carries a therapeutic advantage. Now, this is a simple diagram that illustrates both the recycling and the transcytosis process of the Fc receptor. So as we said, this is an intracellular receptor. It binds to the immunoglobulin, specifically the IgG, and binding them prevent the degradation inside the lysosomes. So recycling them and releasing them again into the bloodstream, prolonging their half-life. This is for the recycling process. For the transcytosis process, it's the same. They would bind to it and then transfer it to the opposite side. So neonatal Fc receptor is involved in the autoimmunity by prolonging the half-life of the pathogenic autoantibodies, specifically the IgG. And we know that the autoantibodies, of course, they are a major contributor of many of the autoimmune disease. So targeting the Fc receptor and blocking it will help to prevent prolonging the half-life of these autoantibodies by preventing the recycling process. And as you can see, blocking the Fc receptor and reducing the level of the IgG, it works in the same way of the plasma exchange and the IVIG. Now, the efgartigimod is first-in-class neonatal Fc receptor antagonist. So it will bind to the Fc receptor, preventing the interaction with the pathogenic IgG, reducing the recycling process, hence increasing the lysosomal degradation of the IgG and reducing its level in the blood. IV efgartigimod was initially approved in 2021 in the United States for generalized myasthenia gravis, specifically for patients who are positive for the acetylcholine receptor. In 2022, efgartigimod was approved in Japan for generalized myasthenia gravis, regardless of the antibody status. And the recommended dosage of the efgartigimod in the trials was 10 milligrams per kg once weekly for 4 weeks as one treatment cycle. And then other cycles will be administered based on the clinical picture and the need of the patient. In healthy volunteers, single dose of efgartigimod reduced the level of the antibodies up to 50%. Multiple doses reduced it even more than 85%. And the total IgG level returned back to baseline by week 8. Now, here you can see, this is the recycling process without the medication. Here you have the pathogenic immunoglobulin, IgG, and this is the neonatal Fc receptor binding to it inside the endosome, protecting it. Whichever immunoglobulin that is not bound, it would be degraded inside the lysosome. Whichever that is bound to the neonatal receptor, it would be released back again to the bloodstream, prolonging its half-life. Now, efgartigimod, it would bind to the neonatal Fc receptor, competing with the immunoglobulin to prevent its binding, and increasing the lysosomal degradation. And once they want to recycle it back, the level is lower compared to here when the drug is not there. So this is how efgartigimod simply works. These are my references, and thank you very much.